All right. So, okay. Let me start from beginning. So, uh, for this group, then I'll be quick in epidemiology because everybody knows the epilepsy landscape. A few things to emphasize: the incidence and prevalence of active epilepsy is greatest in low and middle-income countries, including Africa. And the prevalence of epilepsy is higher in rural areas than in urban areas. Part of the reason could be many of the risk factors for epilepsy are also higher in Africa and in rural areas. Examples of these risk factors include CNS infections like meningitis, encephalitis, perinatal insults, traumatic brain injury, which are commoner in low and middle income countries, including Africa. Epilepsy is a big contributor for global burden of disease. It's estimated as 0.7%. And as you all are aware, most of epilepsy starts in childhood, and more than 60% of epilepsy starts before the age of 13. Epilepsy is a big contributor to premature mortality, and the mortality appears to be higher in Africa. There are multiple proximate causes of mortality related to epilepsy. These include sudden unexpected death in epilepsy, status epilepticus, where you have prolonged seizures lasting more than half an hour, drowning, burns, and suicide are also additional contributors to mortality. So overall, the estimate is epilepsy-related premature mortality is 3 times higher than the normal population. Epilepsy is associated with multiple physical and psychiatric comorbidities. Depression, anxiety, and intellectual disabilities are particularly common in people with epilepsy. And epilepsy, as you all know, is a treatable condition. Up to 70% of people with epilepsy could become seizure-free with anti-seizure medications, with either the first or second anti-seizure medication. That's the good news. And another good news regarding epilepsy is cheap and effective anti-seizure medications are available. However, the sad part, more than 75% of people with epilepsy in low-income countries do not receive anti-seizure treatment. And left untreated, people living with epilepsy face devastating social consequences, including stigma, discrimination, and human rights violations. So what are the challenges in terms of epilepsy? The first challenge is lack of access. Most of the services regarding epilepsy tend to cluster in big cities. The story is the same throughout Africa, and the same thing is true in Ethiopia. And none of these services are available for rural populations. Another challenge, cultural beliefs about the cause of epilepsy are largely related to spiritual belief system. Stigma is rampant with epilepsy throughout the world and more so in Africa. And that would result in reduced opportunities for education, employment, and marriage. There was one study that I wanted to quote regarding public knowledge and attitude towards epilepsy. It was a community-based study performed in central Ethiopia in a place called Debre Berhanu, with a population of about 108,000. They included 596 households, and 65% of the respondents did have high school and above level of education. So this is a pretty urban population. So the findings, for 56% of the responders, the source of their information about epilepsy were family and friends. This is in a place where we have a referral hospital in the town. 47% believed epilepsy is caused by evil spirits. 42% believe traditional medicine is the best treatment for epilepsy. And 27% said epilepsy is contagious. So as you can see, there is a lot of knowledge gap, even for this relatively urban study population. The story would be, as you can imagine, would be worse if you go to rural areas with very little education and far from medical services. Additional challenges regarding epilepsy care include lack of adequate training of health workers about epilepsy. Now, wherever I go, I check with health workers about their level of comfort in diagnosing and treating epilepsy. And the answer is the same. So they say they keep on refilling medications and they would need additional training to be able to do that appropriately. The few neurologists that are available throughout Africa, including Ethiopia, are concentrated in the big cities. So most of the neurologists are in big cities like Addis Ababa in the Ethiopian context. And very few practice outside the big cities. There is lack of access to neurodiagnostics, including electroencephalogram and neuroimaging in a few centers, and they are expensive. Anti-seizure drugs availability is variable in the Ethiopian context. One or more anti-seizure drugs would be available in most health centers and hospitals. However, at times, the supply may not be consistent. So there are times when the institutions run out of essential anti-seizure medications. The cost in government hospitals are reasonable, but if these medications are not available in the government institutions, people have to pay a lot of money to get those drugs from private pharmacies. So they become expensive when they are not available in government facilities. This is a study which looked at the distribution of neuroimaging in East Africa. And as you can see, in Ethiopia, for instance, there are only 11 MRI machines for a population of 112 million. And the story is not different in the rest of East Africa. The first point of contact for person with epilepsy, as you all know, are traditional healers. 60 to 80% of people with epilepsy have seen traditional healers before coming to health institutions. That's kind of the story throughout Africa, including Ethiopia. The reasons are many. Some reasons include physical access. The access to modern health services is challenging for most in rural areas particularly. And the traditional healers and the religious healers offer plausible explanation of disease causality, which is commensurate with prevailing attitude in the community. I also think that the belief that epilepsy cannot be cured by medications is kind of deep-rooted, at least in Ethiopia, and I suspect it is the same is true probably in the rest of Africa, and therefore people would try traditional therapies first before they show up to health institutions. Additional reasons could be the focus on psychological and social context by the traditional healers. More than 75% of people with epilepsy are not getting anti-seizure medications, as I indicated earlier. And I think the story is similar in most of Africa. And those who start treatment are not compliant with medications too. I think studies that have been done in Ethiopia, up to 2 out of 3 people with epilepsy who have been started on medication do not take their medications on a regular basis. And a large number of them would stop taking medications. In some studies, the default rate is up to 60%. There are multiple reasons for this poor compliance. One reason which is often cited is the distance from clinic. So the closer the clinic is, it's more likely the person would continue to take medications on a regular basis. Another reason for poor compliance is limited access to anti-seizure drugs. Cost could be also a reason for poor compliance. There is preference of traditional medicine, lack of understanding of the nature of the disease. Sometimes families would try the medication for a short period of time. If they don't see any seizures, they assume that's done, they stop treatment. So there are multiple reasons for poor compliance. One study which was done in Ethiopia, which tried to look at the causes of falls from follow-up, found an interesting finding in my view. If you look at the results section, 113 patients who didn't show up for follow-up in clinic were traced. And when they investigated, 25% had died, 19% had moved from the area. Of the remaining 64 patients, 44 patients were still experiencing seizures, but they were not on any treatment. I'm talking about anti-seizure medications, or they had reverted to traditional remedies. So about more than 2/3 of the patients have stopped medication, although they continue to have seizures. And the main reason for default was difficulty in traveling to the health center. So again, distance comes up as the most important factor in compliance issues. Another point, the number of neurosurgeons in Ethiopia has increased in recent years. There are fellowship and residency training available in Ethiopia, but access to epilepsy surgery is very low. And this in the background of a carefully selected patients undergoing epilepsy surgery had a better chance of cure than as compared to medications. Again, this is in early stage, but I think it is probably appropriate to start the conversation about those surgical options now. There are several resources we can tap to when we are thinking of improving epilepsy services and epilepsy care. One or more anti-seizure drugs are available in most health institutions in Ethiopia. The few institutions I surveyed, like health centers and hospitals, carry some anti-seizure drugs. As I said earlier, it is sometimes they run out of medications, but one or more medications could be available in most health institutions. There are various models that have been tried in Ethiopia, including a chronic disease follow-up model, which has been actually tried in two major hospital centers in Jimma and Gondar in Ethiopia, with mobile clinic from the referral teaching hospital to health centers. This has been very helpful in improving access to epilepsy care. And task shifting models for epilepsy care have been tried, particularly integration of epilepsy care with behavioral psychiatric care has been tried with good results. So it is feasible to integrate epilepsy treatment into primary health care. There are several experiences from Africa, from Ghana, Mozambique. The World Health Organization has piloted it. It works. So training non-specialist providers, investing in continuous supplies of anti-seizure medicines, and strengthening health systems can substantially reduce the epilepsy treatment gap. So what are the actions that need to be taken? First, I think everybody would agree, training of health workers on epilepsy diagnosis, treatment, and follow-up is needed. Integrating epilepsy care in primary health care, task shifting model, utilizing non-neurologist providers, because we have very few neurologists in Africa, and the story is the same in Ethiopia. Epilepsy can be diagnosed and treated at the local health institutions, be it at health centers and hospitals. So training would be a key part of the improving access in epilepsy care. The public should be made aware of the availability of the epilepsy services too. Sometimes services are available, but people do not know about the existence of those services and have to travel long distances to get the same services. Raising awareness about epilepsy, most of you guys are working on that. Epilepsy education to the public, religious leaders, teachers, families, patients, community health workers would have a great impact in improving access to epilepsy care. Improving access to EEG and neuroimaging is part of improving the quality of care. Improving access to anti-seizure drugs, numbers, different category of drugs. I think this is something that need to be worked on. Education about medication compliance, strengthening referral centers, multidisciplinary approach to epilepsy care would definitely improve quality of care. Psychiatry, neurology, social worker, pharmacists, physicians, I think everything and everybody needs to work together to improve quality of care. The WHO has suggested a stepped model to improve quality of care for people with epilepsy. At all levels, public awareness of epilepsy, its symptoms and effects need to be done. And at all levels, treatment of comorbidity should be done. Social and education services should be available for the individual with epilepsy. In level 1, primary care for initial identification of symptoms, diagnosis, and basic medication treatment. Level 2, specialist care, adjunct test for optimal diagnosis and modification of treatment. In level 3, you have comprehensive pharmacological and non-pharmacological treatment, including surgical treatment of epilepsy. So this step model can improve quality of care. I suspect most of the individuals with epilepsy could be managed at level 1, but those who do not respond to treatment or who needs additional investigation and expert care could be referred to level 2 and 3 as needed. Not much has been done regarding epilepsy prevention, but it's estimated that about 25% of epilepsy cases are preventable. The major modifiable risk factors for epilepsy are perinatal insults, such as perinatal asphyxia, perinatal injuries, central nervous system infections like meningitis, encephalitis, cerebral malaria goes into that too. Traumatic brain injury, stroke are the preventable causes of epilepsy. Effective interventions for prevention are available and delivered as part of broader public health responses in maternal and newborn health care, communicable disease control, injury prevention, and cardiovascular health. The other issue is sustainability. Well, we start a lot of interventions, but how can we make them sustainable? Health institutions and the Ministry of Health should integrate epilepsy care at every level. That's the only way to ensure sustainability. Oftentimes, high turnover of health workers has been mentioned as a barrier to sustainability. People train health workers on epilepsy management, but those trained individuals will live to a different place. So I think the training has to be continuous, and the training has to be integrated in the curriculum of all categories of health workers training in the first place. So if we do that, we have a better chance of sustaining the epilepsy care. Any complex problem needs concerted effort, so collaboration is key. Ministry of Health, professional associations, epilepsy advocacy groups, epilepsy professionals, the International League Against Epilepsy, the World Health Organization, everyone has a role in improving access to epilepsy care. Research is also needed. It has to be, most of the interventions regarding epilepsy and access to epilepsy care need to be based on need assessment. Intervention plan need to be designed, and cost-effective interventions should be promoted. And to answer this kind of questions, research should be integrated as part of the service. This is from the WHO, Epilepsy, a public health imperative. The time to act is now. Promote epilepsy as a public health priority to reduce its burden, improve public attitudes, reduce stigma, and promote protection of the rights of people with epilepsy. Invest in health and social care systems to improve accessibility to epilepsy care, enhance access to cost-effective anti-seizure medications globally, prevent acquired epilepsies through improved care for common causes such as perinatal injury, CNS infections, stroke, and traumatic brain injuries. Increase priority given to epilepsy in research agendas. These are the references I used in preparation of this material. Thank you, and I will be happy to answer any questions.
Okay, thank you, Dr. Tesfaye. If you kind of come out of the screen, yeah, that's better. Okay, why don't we take a few minutes to ask questions directly to Dr. Tesfaye while everything is fresh in our mind. Yes, so I'll open the floor to everyone, anyone who has a question.